seemingly every tuberculosis patient, this occurs at some point. So when we treat tuberculosis, we use 4 drugs initially. All 4 of those drugs are hepatotoxic. And when you're using all 4 of those drugs for months at a time, hepatotoxicity often occurs. So there are many a times when we're not using first-line therapy because a patient develops this hepatotoxicity that we have to use second or third or even fourth-line agents to try and circumvent that.
In terms of the community setting where you might see that happen, the biggest drug I could think of would end up being Accutane. The patients have to go once a month and get their liver enzymes checked because it's very hepatotoxic. And so if you have a patient come in 1 month with a certain dose and another month with the same dose, maybe they're looking a little funny or something like that, like you can go ahead and make sure that, yes, this dose was adjusted appropriately based on that. And that's something that you could verify and call with the doctor saying, hey, are their liver enzymes okay enough for this dose?
Yeah, and on the inpatient side of things, you're going to be closely monitoring for signs and symptoms of toxicity, watching for worsening liver function, all that, and adjusting your doses based on that. There's no one right way to do it. I think it's very much a case-by-case basis. What signs are the patient showing? Is the drug working? Do we need to reduce the dose? Do we need to just scrap it and try something different altogether?
Right. I think another inpatient example would be a lot of your opiates. A lot of your opiates get converted in the liver, and so if you give a patient a 4 milligram dose of morphine and they are completely knocked out unconscious, okay, so they're probably not eliminating that appropriately. Let's back off on the dose. And so usually it's more of a trial and error kind of deal, and you go based on what are the adverse effects that are happening versus let me preemptively dose adjust for liver dysfunction. Some drugs you can do that. You can do that for our antibiotic tigecycline. You have to calculate Child-Pugh, and based on that, you have to preemptively dose adjust that drug to a lower dose if you have some liver dysfunction. So some drugs you can do that, some of them you have to go by side effects.